Dean's going to lead us in our discussion. And with that, Dean, I'll give it to you.
Thank you. Okay, our first question, I guess, might be for you, Dr. Harley. What is the role of nosebleeds and nasal infections, sores, in pandas? And should pandas patients receive nasal swabs or cultures?
Well, yeah, thanks for the question. Well, the role of nosebleeds, we do know that sometimes we actually treat nosebleeds with antibiotic ointment. So I think that might be what they're addressing. Their pediatrician or laryngologist may have given them some Bactroban or some bacitracin. So there's some low-grade infection in some patients. But I must say, the most common reason for nosebleeds, by the way, in little kids is they pick their nose. I mean, so it's trauma. So it's not infection, but you know, antibiotics ointments are used. Yes, culture should be obtained. There may be staph, and we showed the staph can Dr. Cleary showed the staph can have some of the same impact as strep, or you may have strep, but well, especially if you have a crusting. I think Dr. Pasternak talked about the impetigo, which is strep mainly. So yes.
Thank you. This is for the entire panel. For parents and healthy siblings of pandas kids that are deemed strep carriers, do you recommend removal of their tonsils, those of the healthy parents and siblings?
Well, I just put that slide up there, but there is such thing as strep eradication, and we have worked with some of our ID doctors doing strep eradication. You can use rifampin, you can use clindamycin. I think Dr. Pasternak says clindamycin is not a great drug, right? No. It's not as good as it was, but I know our ID person sometimes uses rifampin as well. So you can do strep eradication short of tonsillectomy. So I don't know what the rest of the panel.
Is there still an immunoglobulin shortage? And if so, what can we do to help?
Well, I guess it's artificial. They just want to raise the price, okay? There are 12 different preparations on the market right now. And to my knowledge, I haven't seen the shortage. I think it's just artificially, induced.
Are there any studies or information about targeting T cells rather than just B cells?
I'm glad you asked that. Because I think, and I talked to Dr. Belanti again. People don't know, he's a very prominent immunologist at Georgetown. He's written a couple of textbooks. And he also thinks it's a T-cell disease. This is the T-cells. So yes.
What do you think about LDI, low-dose immunotherapy drops? Are they effective, and in what situations?
Yeah, I don't want to take up all the time, but I'm glad you asked that question as well. So I have a colleague in Durham, North Carolina, who I'd hoped would come to this. He's an otolaryngologist who was also a microbiologist before he went to medical school. And he has gotten me into this, and I think I've talked to Diana Pullman about this low-dose immunotherapy. So I don't have all the research, but it's certainly something. I think people are afraid because there's really no FDA indication for using low-dose immunotherapy, but it's something that's out there, and I know he uses it in his office. He doesn't see children, he treats adults, but I know he's using LDI. So.
This next question is actually for you, Doctor.
Which question? Which question?
Rheumatic fever in Africa, do you think it causes more severe pandas in Europe and or Italy?
I don't know why. If there is a rheumatic fever in Africa, okay? I don't know.
Se fa differenza in Italia,
no.
Perché lì è alta.
No, I don't think so.
Okay.
Because we have not so many patients with a rheumatic fever, because now the disease is recognized and the infections related to strep are treated. However, I think, in my mind, I am not sure, that this increasing number of patients with PANDAS disease I am old in the past, I am sure that the disease was not so spread because I'm caring for a big number of patients and not one in the past. I think that important is the now is reduced the treatment of strep infection because mother, father, all are worried about antibiotics as well about the vaccine. So when a child has pain in swelling and not high fever, they don't realize it, that it should be a strep infection. So I don't know what is the name in the States, ma they prefer spruzzano in gola il spray to reduce the pain. So what do you think about the low attention for strep infection now? For this reason, probably is increasing the number of patients with PANDAS. I don't know, probably. But there are other questions, I think, is the situation of many families. The father doesn't agree with the mother, in particular if they were divorced. So father no agree with the treatment in Italy. I don't know in the States. And there is also an infection at the school because they spend many time at the school and they to kindergarten. At my age, we started attending the school at the age of 5 or 6 years, and now children go to school during the first year of their life. During the first year, there are no strep infection, viral infection, but after contamination among sister, brother, I think, and come si dice, la contaminazione ambientale.
Just environment.
Environment and food. Okay?
Can I just add something?
Absolutely, Dr.
I think,
K.
it's important to look at the strep from the hysterical Hey, it's been a long day. I'm from
That too.
Chicago. This scares me here. From historical perspective, when I was a kid, that was like a century ago.
In Africa,
The strep could kill you. You get the scarlet fever, you're dead. Okay?
Okay.
Then in the late 50s and the 60s, the prevalent strep manifestation was rheumatic fever. That disappeared on its own. We don't know why. Then in the 70s, it was streptococcal glomerulonephritis. That disappeared over about a decade, and then we started to see the PANDAS. So the question that nobody has answered yet, let's don't forget, strep is not a single organism. There are 120 different strains of strep. So is there a particular strep strain causing rheumatic fever, particular strep strain causing PANDAS? That's something that has to be looked at. And I think they're looking at it right now.
Thank you. Please explain the difference between a flare and sawtooth recovery. Is there a difference between a flare and sawtooth recovery?
What does the sawtooth mean?
What do you mean?
I'm not certain.
Could you explain it?
Up, down, or recurrence?
Oh, you mean the wax and vein pattern?
Yeah.
Wax and vein pattern basically is a repeated flares. So, you have a flare, then the symptoms go down, you stay down for a while until you have the next flare. So actually there is no difference, it's a part of the evolution of illness.
Do any of you have thoughts on probiotics? Is it important if the child is on long-term antibiotics?
Well, in PANDAS, child should not be on a long-term antibiotics to start with unless you use it as a preventative one after IVIG. And if you are using a year preventative antibiotic that I recommend after IVIG. I think if you take yogurt once a day, that's more than enough. Probiotics are expensive, and they really haven't been proven to have any significant value opposed to plain yogurt. So why to spend the money?
Our next question, do any of you ever use antivirals as opposed to antibiotics in treatment?
In case that I have a positive Epstein-Barr virus,
Yes.
I do use it, and obviously IgM is the one that I'm looking for. I have not used it for any other presence of viruses because I don't think they are related to pandas, except being a cause of the flare. So yes, I have used it, and in some cases I have seen improvement. Unfortunately, at least what I can recall, once you stop the antivirals, the symptoms will come back.
But you do use it sometimes if a virus is the cause of a flare. Is that what I heard you say?
That's exactly right.
Is there any evidence to support the claim that the later in life the first onset of symptoms is observed, the lower the incidence of recurrence?
Well, I think the only explanation I have, and I mentioned it, older the patient is, more likely they're going to have their adenoids and tonsils out, and so less likely they're going to have a recurrence. That's the only explanation I have.
Why are thyroid and antibody levels tested, and what is the relation to PANDAS?
No, I have not tested for it. I don't know if anybody else has done it.
I think they're looking for other autoimmune disorders. I mean, that would be the only reason. I mean, I don't do the testing myself, but that would be the only reason I can think of looking for a thyroiditis like Hashimoto's or something like that.
What long-term problems may occur from a tonsillectomy, and will there be more chance of other infections post-surgery?
Yeah, I know. You're probably quoting some recent stuff in the literature about more allergies, and I haven't seen that. I mean, I just don't, because I've been doing this a long time too. I have not seen, and I've done tonsillectomies in children as young as a year old, of course not for pandas, obviously, and followed these kids because they come back year after year, and I have not seen any long-term problems. Although I know there's within the recent month, there's some literature out there, and I looked over it briefly. It's a big study. It's like thousands of kids, that's reporting more allergies and things like that long term. But we haven't seen that, and we've been doing tonsillectomies for a long time. So I kind of question that study.
How do you treat group A stress found on nasal culture, with no GAS found in throat cultures and no elevated ASO or anti-DNase titers?
I think Dr. Pasnick talked about using mupirocin, I think, is that right, Mark? Mupirocin or?
Mupirocin is a topical antibiotic that's actually very effective against staph and strep. Talk about sort of artifactual shortages. Mupirocin comes in a big tube, and parents are told put a little mupirocin on a Q-tip and sort of tweak your child's nares. It turns out that delivers about 1/10 the amount of medicine that you can deliver if you had a dedicated nasal tube. Mupirocin was manufactured, you got 10 little tubes and you squirted half in each nostril twice a day for 5 days. And it was really very effective treatment for resistant staph. There has been a shortage of nasal mupirocin for probably 2 years now, and if you Google it, there's typically no response as to when it'll be back. I could have built a new factory, and so I don't understand it because they're still making the larger tubes. But I would say if it's in an average kid, I might do nothing, or I might try mupirocin. If it's a PANDAS child with symptoms, I would probably give systemic antibiotics. I wouldn't be shy.
Because this might be for you as well. Has fecal transplant been considered as an option for PANDAS or PANS treatments?
the potential role of the gut microbiome is real. We heard a little bit about it yesterday. The problem in this population is that antibiotics are such a prominent part of the long-term management of these kids, even if they're not on long-term suppressive, if they're getting episodic antibiotics for symptom flares, those antibiotics wipe out the fecal transplant. So the ideal candidate for fecal transplant is a patient who had Clostridial difficile infection, had terrible diarrhea from antibiotics, fails to respond to treatment for C. diff, gets a fecal transplant, and is cured. Since that patient is not likely to be put back on antibiotics, the response is durable, and it goes on, and these people are really cured. For people who are often on antibiotics, like the occasional PANDAS child who gets C. diff, I've only seen 1 or 2 of them, and it's a disaster because you need to give them antibiotics for the PANDAS, and they have C. diff, and so the first rule is don't give antibiotics. I've had, I think, maybe 1 patient who's gotten a fecal transplant and did well with it, but then eventually got antibiotics again. So I don't know if he got immunological benefit from the fecal transplant. He didn't get recurrent C. diff, so that was a plus. But it's an area that really has to be explored further. But I think that whenever this conversation comes up, it's always that this will be fine until your child next needs antibiotics. And if it's a population of kids, like a cystic fibrosis patient or a PANDAS patient who's going to get antibiotics with some regularity, they're just not durable responses because the normal fecal microbiome is highly sensitive to most of the agents we use. And if you give amoxicillin clavulanic acid augmentin, it just like blows the fecal microbiome out of the water.
Thank you. When a PANDAS patient seems to be at 100%, what do you do for maintenance other than prophylactic antibiotics?
Let's remember one thing. You can achieve complete remission following the removal of adenoids and tonsils. I mentioned about 30% or so cases do that. You can get the remission at least early in illness with the course of antibiotics. So if the child is asymptomatic, there is no point in doing anything else. But just kind of note of caution. I've had a while back 8-year-old kid who was patient of mine, just a regular pediatric patient, came from summer spent in Bulgaria with severe OCD symptoms, strep titers positive. We put him on antibiotic. Symptoms went away. We rechecked his strep titers. They went down, and I continued to follow the kid just as a pediatrician for about 4.5 or 5 years. Now, don't quote me on that one. So kid got to about 14.5 without any symptoms. I saw him every year, never anything. At 14.5, wakes up in the morning with the severe tics, OCD, anxiety, etc. Had a strep. That was confirmed. Treated with antibiotics, didn't touch him. So he did have a IVIG immediately following that. So that's what happens.
We know that we shouldn't be giving into the OCD, but what is the best response to intrusive thoughts like, why are we alive, when no explanation seems to be adequate?
All right. First thing is, please.
Or it's for Dr. K. It's okay. Answer. No, answer, please.
I'm sorry.
I want to hear your
I thought he had the
answer.
OCD because he's doing that.
I want to hear your answer. Go ahead.
No.
Please.
Okay. It's simple. These kids have irrational thoughts. Everybody knows that. But guess what? They know that too. So trying to convince them that their thoughts are irrational is basically just pissing them off. I know that. Kid is basically telling you, I know this is irrational, but help me get rid of it. So actually, CBT, counseling, during an acute episode does not work. I never saw the case that it worked. It works once they start improving. So the best as a parent, I believe you can do during those acute stages, first, try and comfort the child the best you can. Second thing is, don't try to rationalize anything. You're just wasting your time. And third, please watch the kid carefully. You never know. They can do self-harm, they can do harm to the others. So please keep your eyes open.
The only thing I would have added to that is without indulging the OCD itself, I think it's really important to give the kid empathy. This sounds like it's really bothering you. The OCD is I don't want to talk to the OCD right now. Let's wait and go into therapy. If you want, I can go with you. Let's talk to your therapist about this. This is where CBT can really help in penetrating the ruminations, in my opinion. I'm an LCSW psychotherapist from Long Island, and I routinely screen patients of all ages for past infections to rule out medical causes. I recommend blood work, and 8 out of 10 times it comes back positive, usually for mycoplasma. An 11-year-old girl with significant PANS symptoms just came back with mycoplasma numbers double the normal limit. Infectious disease doctors said it is not PANS, because to have a PANS diagnosis, it would have to be 4 to 5 times higher. I still think it's PANS, but the parents are deferring to the doctor who said it is not. Your opinions?
Was that an IgG or IgM?
It does not say. It just says that that the child was sent out for blood work and that the mycoplasma numbers were double the normal limit. Yeah. Again, we defer to Dr. Pasternak.
So mycoplasma pneumonia is the cause of walking pneumonia, so-called. It's extremely uncommon, and yet mycoplasma infection is very common. By the time a child is 12 years old, there's probably 95% chance that she had mycoplasma at some time in the past. If it's a typical ELISA assay, and where the upper limit of normal is 1, and a level of 2 is positive, but not that dramatically so. The problem with the conventional testing is that the IgM, often, which is supposed to reflect acute infection, is often elevated for long, long periods of time, and it's often not confirmed by other testing of IgM antibody levels. So it's a false positive, and it's almost inevitably a false positive in a situation like this. If the numbers come back with that are 5 times higher, I do start to get interested. I think the advice or the comments were not unreasonable, but the only way to confirm that is to send blood to the Mayo laboratories. I'm not one of those people who says, oh, you have to send it to my lab because, it's my lab. But I think the Mayo lab does this confirmatory test, and it's reassuring to families to know that the IgM was positive, but in fact, it's not real.
Okay, and with that, we will have
Thank you,
to
panel.
wrap up the panel. Let's show some appreciation to this panel.